Okay, so we're recording right now, and go ahead.
Good morning. This is Sheila Hemphill with Texas Right to Know, and it is a pleasure to be with Dr. Jack McHale. How do you pronounce your name?
Michelle.
Michelle. Dr. Michelle with Larkin Community Hospital in Florida. So I want to thank you, Dr. Michelle, for contacting me regarding the status of the treatment of ozone for treating COVID that is being done in clinical studies in China, Italy, Spain, with pending trials in Romania, Turkey, Brazil, and Portugal. So Dr. Michelle, thank you so much.
My pleasure. My pleasure. We're as we talked about before, Sheila. We're a teaching hospital, so we're two teaching hospitals, and so we have about 400 residents in training in various specialties. And one of the things we'd like to do is obviously try to offer options to our patients who have COVID. So that's our interest in looking at ozone.
Fantastic. Could we have a please brief introduction? And let me see if I can.
So
Yes, please.
let me just give you a quick backup. So this is theme 11. We have 12 teams that dealing with COVID. We have a support team, we have a plasma donation team, we have a clinical guidance team, we have a contact tracing team. This team is specifically just looking at the research aspect of IRB and looking at new treatment options that could be we could put together the IRBs for. So that's the purpose of this team.
Fantastic.
Go ahead, LaDonna. Go name by name so everybody can say hi real quick.
Okay, hello, my name is LaDonna Williams. I'm one of the research assistants to Dr. Marco Sanchez here at Larkin Hospital. Usam, you're next up.
Oh, he's
Usam,
muted.
you're muted.
Yes, good morning, everyone. My name is Ozone Ahmed. I'm a fourth-year medical student from Pakistan, and I'm the research leader for Team 11.
Dr. Sanchez. Dr. M, you're muted.
Thank you, LaDonna. You see, I have to have my right and left brain in the phone call. Dr. Marco Sanchez, I'm the Vice President for Research and Academic Affairs at Larkin Health System.
Beautiful.
Roshan.
Hello, my name is Roshan. I am an intern and medical graduate from Pakistan. I would love to contribute this to research team.
Ryan.
Hi, my name is Ryan. I'm a fourth-year medical student in Chicago, and I love everything research, and excited to support in any way I can.
Dang.
Hi everyone, my name is Dan, and I'm working with Dr. Sanjay at the Larkin Hospital as a research fellow. Thank you.
Omar.
Hello everyone, my name is Omar. I'm a fourth-year medical student from Karachi. I have two classmates over here, that is Ozam and Shataj. So we both are actually working on a small research with us, and currently I've been working on a review article for COVID. So Ozam actually brought up with the idea, and I thought maybe I could join this. So I would like to thank Dr. Jack for this opportunity. That's it.
Shataj.
Hello, my name is Shatash. I'm a fourth-year medical student in Karachi, Pakistan. I'd really appreciate this opportunity to work on this research.
Adarsh.
Good day, everybody. My name is Adarsh Shetty. I'm also a research fellow along with Dang and the rest of the team for the research department at Larkin Hospital. I work under Dr. Marco Sanchez in Dallas. Thank you.
Christina.
Hello, my name is Narch. I'm professor at the North Southeastern University, Fisher College of Education. My expertise in working with children with disabilities and autism. I have an extensive research experience. I'm a dissertation chair and IRB representative. So I'm hoping to contribute to this research.
Ellen.
Oh, hi everyone. My name is Ewan Poland. I'm an ECFMD certified international medical graduate from Nigeria. I'm applying for residency later this year, and I'm happy to contribute to this research work.
Lynette.
Hi, everyone. My name is Leonette. I'm a third-year medical student with American University of Antigua. I don't have any research experience, but I'm very excited to be part of this group and learn as much as I can. Thank you.
Sanjay?
Hello everyone, I'm Sanjay Mahar. I'm ECS MD certified graduate from Nepal. Currently, I'm working as a research assistant here in Nepal, and I hope I can contribute to this group. Thank you for this opportunity, Team Rocket. Thank you.
Sumina?
Hello everyone, I'm Dr. Sumita Sapkota. I'm ECFMG certified physician and international medical graduate from Nepal, and I would like to contribute to this research. Thank you.
Mylanis?
Hi, I'm Melanie Fuentes. I am Dr. Sanchez's left brain, Ladonna's the right brain, and we help him with all research needs.
And finally, Jean? Jean?
I want to say I'm honored. I am so blessed to be here with this moment of time to be able to bring forth what I consider a very long overdue recognition of what this, not even a drug, but a natural substance can do. So I'm going to go ahead and share my screen and kind of show you around of the information that is available at texasrighttoknow.com. What was interesting is that my press release was picked up predominantly by finance groups, Market Watch, Wahoo, Yahoo Finance, Morningstar, Daily Herald, of course, because of the devastation that this pandemic is having on world economies. It is my belief that much of the problems from many levels is the fear of there being no treatment, which is the information that's being conveyed by the CDC, and then the confusing contradictory statements of the FDA's status comments about ozone, which are completely contradicting what the NIH information has regarding ozone therapy. So there's a lot of confusion happening in the legislative arena, which has been parroted by the comments of President Trump taken completely out of context regarding disinfectant. Of course, there are disinfectants, but we're not accustomed to seeing that same word used in regarding to internal use. And that's how come we have to put labels on our packages that says remove wrapper before eating. You know, it's just been ridiculous in my opinion, and it's diverting from very good momentum that should be directed in positive manner. So here's what our CDC is saying. That was as of April 19th. Now, this is what the World Medical Association says from the Declaration of Helsinki, which the United States signed onto. Number 37 of the ethical principles discusses how in the treatment of individual patient where proven interventions do not exist or ineffective, the physician, after seeking expert advice, may use unproven intervention if the physician's judgment it offers hope of saving life, reestablishing health, and alleviating suffering. Well, that's exactly where we are, but we're even in a better position. We're not even talking about unproven. We're talking about clinical trials taking place in China, Italy, and Spain, of where I have reports from, and I have direct communications with a professor with Wuhan University, Dr. Mariano Franzini, who's overseeing the 17 is the last number I had on how many hospitals are utilizing it, and a Dr. Alberto Hernandez overseeing the polyclinic studies taking place in Spain. Now, this, after reading all these articles that are right here that you can link to individually, and I have a new one to put up here, or if you go to the summary, all the articles are collated in that one PDF document. I have a 17-pager to put it on today that I haven't even gotten up yet. But this has been my favorite quote of all of these that sums up what, in my opinion, and let me stress, I am not a medically licensed individual. My degree is in computer science. I wrote patient assessment software for the home healthcare industry. So I had to get to the nuts and bolts of tracking patient conditions and correlating that with physician's orders that then had to be sent on to the state for reporting and then billing. And so I'm intimate in the process of caring for patients, even though I am not a clinical licensed medical practitioner. But I hang out with a bunch of brilliant minds. So I stayed at a Holiday Inn once. So this statement kind of sums it up. To our surprise, we did an analytical control. We observed how the ferritin, a determination from the analysis, is being used as a prognostic marker in this disease, has dropped significantly, and that downward trend continues the following days. There are two key elements in the disease that are unfortunately leading to the death of many patients: a brutal inflammatory effect or cytokine storm, and the affectation of the microcirculation for formation of microthrombi. Now, this is coming from Spain. The same comments were in the interview that you can see with Dr. Franzini up here off my website. And it's done through a translator, so it kind of takes a while. We took out the Italian and just stripped it down to the English questions and the English responses. But I have the whole thing if somebody would like to hear the Italian. So both the Chinese, the document I have from China was on 2 patients. There was a distinct drop in the interleukin-6 marker in both China, Italy, and Spain, which would be indicative of the cytokine storm. According to this specialist, there are several ways to counteract the cytokine storm caused by coronavirus. On one hand, we have the traditional way, administering steroids at high doses. Of course, which comes with that is the highly elevated blood sugar levels and the depression of the immune system. Now, they didn't talk about the blood sugar levels, but that's what happens. On the other hand, by administering high dose vitamin C intravenously or administering ozone, since both are capable of counteracting the cytokine storm and both have virucidal power. Ozone, thanks to its action on red blood cells, improves the transport of oxygen to tissues and consequently the microcirculation by making the blood more fluid and promoting normal values of blood pressure. So, questions so far? That's either a good sign or a bad sign. That means everybody understands or they don't even know enough to ask, but I kind of think everybody's with me. So if I could get a head nod, or how are we doing? I was a teacher. I was an instructor, so I like class. And okay, thank you. So the treatment that is noted in all of these studies is referred to as major hemotherapy, MAH. This is so simple. It just floors me how this has not been jumped on immediately. So ozone is generated from a medical grade generator that has been calibrated and tested for its purity and the concentrations that they are what they say it is. So there are ozone generator manufacturers. Right now we're trying to get what a good standard of testing and approval so that we're not perceived as being trying to have a monopoly for one particular vendor. This is not about financial ventures. This is about trying to save lives and jumpstart our economies, because things are not in good situation. So you take medical grade oxygen, and this particular one is a company out of Canada known as Longevity. The reason I do mention their name is because they are recognized by several different, they're used by NASA, they're used by several different universities, and they have the reports stating their purity, etc. So basically, these are ports that you can come in with a syringe, you fill your port. In this model, I think it's about 6,800, has a little pedal that you insert the syringe and the gas goes directly into the syringe. Because the ozone is heavier than air, You just hold it up and down, and then you go, and I have a video here I can show you of the process.
Yeah, we
Yes?
made a video over the weekend where we did a demonstration. Do you want to see it?
Did everybody here see it?
Not yet.
Not yet? Well, if you would like to, sure.
Just to show you what we're doing to see if you think.
Super. Well, you know, it's pretty simple. You sit there and you draw the blood through gravity feed, and then you go over and you inject the ozone into the bag and you shake it. Is that what y'all did?
Yeah, let me show you real quick. Hold on. Let me just get
Okay, super.
my YouTube channel here. This is your site.
Okay.
1 second. Boy, I can't seem to get into the this toolbar is like in the middle of the hold on a second. Oh, okay, I see what it can do.
Yeah, you kind of have to pull it down. It tries to
Yeah.
kind of stay at the top. Mm-hmm.
And this one's in the middle now. Okay, oh, here it is. One second. Oh, I guess we go back. This is like a new computer for me, so I'm trying to figure it out.
Yeah, you're doing great. You're doing great.
1 second. Okay, so this is.
Hello, I'm Dr. Dan. I'm here at Larkin Community Hospital. We are going to trial some ozone auto chemotherapy on our patients, and we're going to go through a demonstration so we can train some of the nurses and the residents here on how to do it, okay? So before we start, I'd like to introduce you to some of the equipment that's kind of required for ozone auto chemotherapy. Here we have the ozone generator. It has the settings from 0 to 10. It changes the intensity of how quickly the ozone generates. Okay, this is our O2 tank. The O2 tank is hooked up through this plastic tubing to the ozone generator. And then this is where the O2 and O3 come out into this device called the O3 destructor, okay? So anything that comes out of this tube is clean oxygen, all right? And so this is the pediatric regulator that we use on this O2 tank. We don't want to use too large of a tank because it'll break this regulator, okay? So we're gonna set the settings to 1 force per liter, all right? 1 force per liter we set. And then to make sure that it's actually flowing the oxygen into the tank, we hook up the tube and we're gonna open the valve. And then we see that it is actually on, okay? Okay, so once we open up the regulator, we turn on the machine. Oxygen, turn on the oxygen, and then turn on the generator. We give it about 20 seconds to generate the O3. And then we make sure the setting is up to 5 in this case. Here we have a schematic on how much O3 is generated at different flows and different intensity from the generator. So here we're gonna have 1/4 the oxygen, and we want close to 40 concentration with the power of 5 on the generator, okay? So now that we let it run a little bit, we can hook up our syringe to the ozone generator, and then we're going to turn the off button towards this tubing for the valve, okay? And it's gonna fill up. And then when we're done, we turn it off and we're at 20 cc's. And so now we have our O3 in our 20 cc vial or 20 cc syringe, okay? Once we're done with it, there's a certain order that you need
What
to.
was the gamma on that?
You want to shut
I'm
this
sorry?
off first, the generator.
What was the gamma concentration?
And then
I'm not sure.
We're going to shut off the valve here. The
That was
PDX
just a little
valve
demonstration they were doing.
to off. And that's how we fill in the O3 syringe. Okay. So
I'm really glad to see your longevity there. That's good.
he's leading the Ozone autohemotherapy. We are testing it out on him. We have put a line into his vein here after flushing the entire catheter with heparin. And so now the blood is flowing down into this bag. The higher, the better. We are going to fill about to that 2.5 mark. And then we're going to infuse ozone in it afterwards, okay? This takes a little bit of time. And then we're gonna hang that bag up and inject ozone into it. So we are now infusing ozone, O3, into the bag after collecting 200 cc's of blood from Dr. Richter. Notice how the bubbles are being slowly infused, and it needs to be very slow.
They did this on Saturday.
So this syringe is still intact. Yeah. So we are done. So before we start, we're gonna rock it. Yeah, rock it back and forth.
Okay, so we don't want to break the red blood cells, or we just do. Yeah, it's like 10 seconds.
Just slowly mixing it.
That's Medelis.
That's good, like that, Doc?
Yeah, that's good. That's all. Yeah.
And then we're gonna hang it up.
Just let it sit there for 5 more seconds, and that's it. And we just can.
I'm gonna lower you.
Yeah.
We're gonna lower his table. So that's the rest of the blood with the ozone. It's slowly flowing down into the catheter.
El ozono, porque quieren tratar de hacer. Doctor,
Down into
para que
his
le expliques
arm.
a ella el proceso del ozono en la sangre.
Okay. Hi, Dr. Richter. And you're feeling okay, right?
Yes.
Perfect.
Doing great.
So we are finishing with the transfusion. We're flushing the rest of the blood. And then we are complete. And now he is fully oxygenated.
So what did you think? We can't hear you. Oh, you're on the phone? Sheila? I think we lost your
Okay, so
audio.
let's go over how to properly don and doff personal protective equipment,
Oh, let me see.
PPE.
Wait.
In particular, this is going to be PPE for airborne, droplet, and contact precautions. We'll start off with the donning or putting.
Sorry. Everybody, can everybody hear me? All right. I think Don's on the phone.
I'm sorry. I'm trying to get Dr. Thorpe.
Oh, good. No, go ahead. Don't
Who's
worry.
on the phone?
We'll wait for you. Marcos, so I guess.
Okay, join in.
Oh, okay. He's joining? Okay.
Yes, I'm sorry. At the end of the video, I watched it through where they were shaking it, and Dr. Thorpe called. So I'm trying to get him the link so he can join in, so y'all can meet him too, and we can
Yeah, that'd be
team up
great.
on
That-
the
that we
IRB
could-
that we're working on and try to expedite this.
Yeah.
He's in between calls, so I just emailed him the link. So he's going to be able to hop in. Something I might just give a little tidbit is when you do videos, if you'll do them long ways instead of parallel,
Yeah, I know.
the videographers prefer yeah. That was great. That was excellent. In fact, I would love to be able to use that.
Yeah,
I'm
absolutely.
not the one talking about these things. I'm just grateful to get what
I'll send
those
it.
are just little, okay, so that's fantastic. Now, isn't that beautiful? There's something as simplistic as patients that are familiar with donating blood. I mean, that's kind of their whole involvement is somewhat an event of donating blood and getting ozone in it and giving it back to them.
Yeah.
How long do y'all anticipate that process taking?
You mean that,
Do y'all consider that a 30-minute process?
about, yeah, that's about how long it took.
The whole process of the,
Yep.
about 30 minutes?
About.
Okay. Now, what Dr. Thorpe has been working on, he has been working on the hypoxia aspect of doing experiments of dropping the O2 sats through a hood over 4 minutes, dropping it down to like 56 on your O2, like right before you pass out. So
Wow.
then they take the hood off and the individual comes back to baseline of blood pressure, overall well-being, their O2 sats, and their pulse is normal. Now, this is a person who's been a trained athlete who's familiar with the hypoxia induced from hyper activity. So it's done in a very safe environment. But what was interesting, when he got an IV of ozonated saline and repeated the hood and desaturation of the O2, at the same 4-minute time frame, he only dropped to like 86. I was like, I think it's 85. So there was a 30-point increase, which clearly is a simple means of showing the beneficial effects of oxygenation of a simple ozonated saline IV.
Got it.
I'm impressed.
Yeah.
So,
I think the doctor's on the line. James?
yes, Jim, Dr. James Thorpe. So please know I highly respect everyone's titles. Working with this international group, I have been challenged on name pronunciations. So if anybody has nicknames or what they go by. So let's see. I bet he needs to unmute.
Actually, he's not muted. Can you hear us, doctor?
Oh, you know what? He has problems with his system in Zoom. He can, let me see, I might have to patch him in through a call, which won't be great. His computer has, he can't hear us.
I can hear you now.
Oh, you can hear me now, but you left the meeting. Try to come back in. Okay. Can y'all, well, I've got you sounded now. Can y'all hear him? Speak, Jim.
Yeah.
Okay, go ahead and give your intro.
Hey, can everybody hear me?
Yes.
Okay. Good afternoon, or good morning, I guess it is. My name is Dr. Jim Thorpe, T-H-O-R-P, and I have been working with Sheila for quite some time, but even longer, I've been following the ozone and the clinical application for well over 2 years. I have a keen interest. I'm working with team members of the Surgeon General who have actually been up and visited 2 of my trial runs and are keenly interested. They're keenly interested in funding a multi-center trial, which I have designed. I've looked at all the data from Italy, from Spain, and from Wuhan, and I have developed the hypothesis to test. I have tested, I have generated all of the statistics, developed a sample size and specific protocol. which will be easy to do. We need 30 to 50 centers. I would love to work with you and have you be my principal investigator down there on this team. I have sent Sheila just a short, what the Surgeon General team requested from me was a 2-page white paper, a little bit longer, detailing the current study that I'm doing in the altitude simulators, and then more importantly, and you can look at that. I gave you a copy of that. It's pretty stunning. They're pretty juiced up about that, and but more importantly, the multi-center trial which I have proposed. They're very interested in that. So I'll let the white paper I've also designed a compassionate care IRB generic protocol that anybody in the world can download from my site, and with a consent form for the use, so that any doctor in the world, in the United States of America, in any hospital, can download my IRB, can submit it to their IRB, and they have a specific protocol that they can use as an inpatient or an outpatient protocol. They can use the Ozone. So I will share all that with you. There's 3 documents, Sheila, that I just sent you, and I didn't catch, I'm sorry that I'm not on the meeting format, but Doctor, I did not catch your name.
So I'm Dr. Jack Michel. I'm the designated institutional official for the hospital. And so this is our research team. We have a bunch of teams for COVID, and this is the one that's in charge of actually putting the IRB together. We have an internal IRB. Our interest, doctor, is to, even though we have a pool of about 1,200 positives that we tested in our own drive-through, we're basically working with them for plasma transfusions. We're more interested on inpatient, people that are in an inpatient service. We're not really, I don't think we have the ability to do outpatient right now, but we would definitely would love to start using it on the people that are sick in the floors, that as an adjuvant therapy. So we can count us in for that.
Used. Exactly right on. The question I have for you, doctor, is do you want to participate in the clinical trial, or are you just looking for starting up your own compassionate care use there?
No, we want to, I mean, we're a teaching hospital. I should have started by saying that. So we're a system of 3 hospitals, 2 of which are teaching hospitals. We have 400 residents in training in pretty much every specialty. Some of those residents are in this meeting today. And so we obviously, we want to be involved in the scholarly activity of documenting what the results are. Let me ask you a question. Is this happening anywhere else in the country? Are we like the first ones, or?
No, I mean, I've been using it for quite some time. Actually, I'm working with a physician right now we are collaborating. She's locally. She's been using it for 10 years.
Well, most of the use has been limited to sole practitioners. I'm not aware of hospital. So as far as you know, Jack.
I posted that video, Sheila, yesterday. It's had like 400 views, and most people are okay, but there's a couple of people that are calling it witchcraft and this and that. And what upsets me about those types of comments is these are people that are sitting at home watching the internet, right? So
they're the same people that do the Tide Pod eating,
Well, but this is my argument, is you're telling people that are risking their lives every day by showing up to work with treating people with a deadly disease that you don't agree with them offering this treatment, which may be life-saving, because you don't like it? I mean, are you really seriously telling me that? So it kind of, I think, because they talk about that DOJ lawsuit in Texas and I wish the government, understood how difficult they make it for research when they insert politics into it. You know, I think maybe they could have handled that in a different way, because now kind of everybody doesn't want to be involved with it.
Let me, this is Dr. Marco Sanchez. I'm the Vice President for Research Academy Affairs. There's two different topics here, and this has to be very clear because we're confusing research with clinical care, and they're different dimensions, okay? The research component, the multi-center IRB approval, I would love to see those forms because probably we can jump in to participate into that specific trial, because this trial, it's actually gonna eventually generate the guideline that every physician is gonna use for treating COVID, common flu, or whatever that is, okay? That's the first part. So the IRB will take a look at the ethics for it. However, if we want to implement and use it as an immediate treatment, because we understand based on prior, countries that they are 6 or 8 months ahead of us dealing with this. Even now in South Korea, we have double positives, but that's another story. We can use the compassionate care because, as mentioned, for the Department of Health and Human Services, for clinical activities, we don't need an IRB. So very different things. Now, in this opportunity, I believe it's Dr. Jean Schwartz. You have both. You have the opportunity to do both, okay? So we can still have some patients receiving the treatment.
Sheila, you're muted. You trying to say something?
Wait, Jim. Wait, I'm not muted. Can you hear me?
Now we can hear you. Yeah, sorry. Go ahead.
Okay, y'all, you need to watch me because the mic's tied to someone and Jim's gonna need to go. So when I do this, that means whoever's talking, we need to pause a minute. So, because the Zoom meeting controls whoever's speaking on the mic and you can't hear other comments. So go ahead, Jim.
Okay, I'm sorry, doctors. I'm in the middle of like 3 consultations of critical patients up in the St. Louis area, Missouri, and Illinois.
Go ahead.
What I want to say is what I heard you say is there are 2 completely different aspects, and you're absolutely right, doctor, and I have both of them covered. Number one, I will support you. You can download, Sheila will copy 3 documents to you. They're preliminary worksheets. I can help you, number one, use it as a compassionate care protocol right now, yesterday, today, or tomorrow in any patient you want. And that is a completely separate issue than the randomized controlled prospective trial. You can implement the use of ozone therapy right now, and I will help you do that. And that's not part of a study. You're absolutely right, doctor. That is a completely separate issue. So that when we do get the trial set up, you can keep using ozone compassionately in every patient you want. But then I would really encourage you, when we do get the multi-center trial up and running, I really would value your participation in that study.
And input.
And let me just say one other thing, that any way that I can be of use to any of you, Sheila will send you my contact information, my email, and my cell phone, and I'm happy. I feel very experienced. I've used all of the different ozone therapies. I feel very comfortable with a variety of protocols, and I can be of service to you and your patients, assist you or the IRB in any way that I can help.
Thank you, Jim.
Thank you, Doc.
I'm going to have to sign off.
Okay.
But
No
thank
problem.
you so
We'll stay in
much.
touch.
I want to say one other thing, Sheila.
Yeah, go
Yes.
ahead.
Yes.
Okay, this is important too. I know that this is just for your inpatients right now. I understand that, but I want you to think out of the box a little bit more on this, doctors. I want Sheila and I guarantee you, we can find practitioners down there that are using it as an outpatient, and we can provide you with their names, and we can get patients also treated as an outpatient in a compassionate care, so you're not overloaded with inpatients. And I would strongly encourage you to think about that option too, because this is very, very, very safe as an outpatient. In the clinical trial, you'll see that I've designed, and again, we can use it. The clinical trial and the compassionate care use are two completely different issues. We can do both the compassionate care as an inpatient and outpatient right now. We could have done it 3 months ago. So think about that. You have my contact numbers. I really look forward. You guys are doing the right thing. You're going to get a lot of criticism, but just remember, so did Ignaz Philip Semmelweis and all of the other people that came up with the brilliant ideas that you have independently come up with. You're spot on. We need to move forward with science, and don't worry about the criticism.
Thank you, Tom. Thank you.
I gotta go.
Bye. Okay. Well, with that, we are coming up on the 11:30 marker. I would recommend, Jack, that you go ahead and close out this video so it's not too large.
Okay.
But I'm certainly available. I don't know everybody else's availability. And I don't know if we need to